This conference will now be recorded.
All right, good morning, everyone. Thank you all for joining this month's HCCN Connection. We will be having a presentation from CliniSync today on the 21st Century Cures Act and interoperability and the information blocking rule that will be impacting you all coming April, and kind of how you're sharing relative patient information through the HIE with CliniSync and their team here with Kathy Costello, Director of CliniSync Plus Services, and Scott Mash, Director of Consulting Operations and HIE Outreach. We will have just a few updates at the end from our HCCN team, giving some updates on webinars and things like that. So with that, I'll turn it over to you, Kathy and Scott, to take it away.
Hey, thanks so much. Can you all hear me okay? Scott, am I?
Yep, we can hear you.
Okay.
Hey, you sound great, Kat.
As you all know, I think just I was running through the list of people and sites, and I know just about all of you have heard Scott and me at least once, if not numerous times, on issues relating to connectivity and, you know, originally it was meaningful use, and now, you know, promoting interoperability and going on to other things. But what I'd like to do today is to kind of give you a different spin, and we are going to end up talking at the end about the technology and the connectivity issues that come into the Cures Act. But I'd like to give you a little bit different perspective and what all is included under the Cures Act that's going to affect you all as covered entities in treating providers, that is a little bit broader than what I usually see people talk about when they talk about the Cures Act. So let's go to the next slide, Scott. As we were just mentioning a minute ago, the effective date, it's been pushed back twice now, but the effective date for the new regulations on interoperability and information blocking go into effect in April 5th of this year. There is some speculation that maybe as we get the change of administration in Washington, they might push it back one more time. I know there's been some requests to do that, but honestly, they've pushed it back twice already. So I would assume that everyone should be shooting for April 5th as being the time when you want to make sure you're in compliance. Okay, next slide, please. Keep going, Scott, one more. The question of how is interoperability defined, it seems like it should be relatively straightforward, and the actual definition in the regulations is pretty short and sweet. It's interoperability is technology that allows the secure exchange of electronic health information from other health information technology systems. So basically, it's the ability to move data between unlike systems easily. So there's two things in that definition I want to point out to you. The first one is the word secure, and I should probably change that and put it all in caps, because I know most of you are no longer doing meaningful use. I mean, even though many of you had Medicaid providers and we're getting incentives for that, and that required you to do a privacy and security review. And I didn't notice in the UDS reports that you're required to do that, but I would highly, highly, highly encourage you to go back to doing an annual privacy and security review, because we just are in an area right now with all the cybersecurity attacks and stuff that you really need to be sensitive to that. And the other thing, should you ever be audited due to a breach or something, that's important that you be able to demonstrate that you have stayed up on your privacy and security reviews. So keep that in mind. And the other thing that on that definition that I point out is the concept of easily transmissible. between unlike systems. So this isn't supposed to be a project that makes it extremely difficult on you, but that's why you work together as a team to get this stuff done. So let's go to the next slide. When you're talking interoperability, the other side of interoperability is how you can do it easily. The other side of that is information blocking. And again, it's very short definition. It's a practice that is likely to interfere with, prevent, or discourage access or exchange of information. And in the case of providers, you have to know that you're doing it. I mean, it's not something where someone can say, hey, by the way, I'm not getting some type of information from you, and you're like, oh, I didn't know that. You know, it's getting blocked because something's not working with my electronic connections, you know, stuff like that. That's not information blocking. Information blocking is when you are consciously doing something to prevent information from flowing. So keep those two definitions in mind as we go through. Okay, go on, Scott, next slide. When you're thinking of the Cures Act, you have to think in more than one bucket as far as the technology issues. Clearly, there's the technology in the need to be connected as part of a broader sum, you know, through the HIE, through, you know, vendor issues, stuff like that. But that's one side. That's the one that most people talk about, and when they're referring to interoperability. But I'm telling you now, don't miss the other part of interoperability of the Cures Act, and that is the patient access to their own information. And the reason I'm saying that is patient access had the Office of Civil Rights, which oversees HIPAA, OCR is what it's usually called, had put out a year ago a declaration that this was a year of patient access to their information. And they were going to give the highest priority to enforcement actions for cases of providers and hospitals not releasing patient information. And they were as good as their word. They have put out, on an average of more than one a month, consent decrees around various specific issues about how people are supposed to release data to the patient. And these all have had fines attached. They all have had other requirements, which we'll talk about in a minute. So I just want to raise your sensitivity to this issue. I know that you're all ambulatory providers, so you're probably less likely to be the number of requests that have that you will not have the same number of requests that a hospital does, but you still need to go through the steps to make sure you're giving access. So let's go on to the next slide, please. One of the things CMS is requiring to make sure that people are giving patients access in the way they want it is last year and the year before, for those people that were doing promoting interoperability, you know, one of the requirements was patient access to records. And as part of that, CMS was requiring that everybody have the connection to create a pathway to phone apps, so that phone apps that would pull the patient's data you had to have what's called an API, an application programming interface. And I think most of the vendors, we know most of your vendors pretty well, and most of them already offer those phone apps. But I'm just telling you, this is a high priority because it comes in again, and I'll tell you why in just a minute. Okay, go on.
Are you going to do Kate's specialty?
I don't know.
Okay. All right. One of the things to keep in mind around patient access, and huge issue right now, is that a couple of weeks ago, right before Christmas, I don't know what it is about CMS releasing stuff right before holidays, but they released a draft of a major HIPAA update that was started 2 years ago. And I don't know if any of you contributed information to this, but CMS had put out 2 years ago basically a questionnaire that had over 150 questions, which had, some of them had 8, 9 parts to them underneath. There was a lot of asking questions about how HIPAA was impacting your practice and problems you saw, and, you know, how do you do this or how do you do that? How do you coordinate care with this HIPAA problem? So they put this out 2 years ago, and 2 weeks ago, they put out a draft regulation. And the reason I'm doing air quotes around the word draft is because it was very interesting that this time of lame duck between, not just between sessions, but in this case, between administrations, presents some very interesting challenges for regulations that may be need continuous care. And obviously HIPAA, being as major as it is and being worked on now for over 2 years, is one of those areas that isn't just going to be decided overnight. But because of the change of administration, the policy, the HIPAA update was not put out as an official proposed rule. It instead was put out in what we call a display format, where it was published by OCR, but it is not in the network or, to actually publish it by the Federal Register, have official comments, have it come back through in final form. So we're kind of at that pre-stage. And so it gives you an idea of what the rule is going to look like, but we're not at the stage yet that you can comment on it. But you need to be aware of what's in that, and we'll come back through after this gets into the official rulemaking process, because it's just too important an issue to ignore. I mean, HIPAA updates are always very major. But in this one, what you see is the whole patient access is one of the key elements of what the HIPAA updates go to. So all those consent decrees I told you about that OCR had put out in the past year now appear in the rule, but in specific guidance. And they say, do this, do that, do that. So there's a lot of detail to that. That's the type of stuff you don't want to get into until that rule becomes final, but you need to be aware that it's coming. The second thing, and we'll come back to this because I do think it affects a lot of you, is there's a new carve out for HIPAA that is being recommended that would give access to patient information and medical records to family and caregivers in cases involving, especially you're thinking like teenagers, young adults, involving SUD, severe and persistent mental illness, or emergency cases. So they're talking about different type of access, and we'll look at that. And the third thing, and this is key to a lot of what you all do as far as the work that you do in the Medicaid CPC program and some other payer coordinated programs, but the question of the ability to release data for care coordination and case management. So those are the 3 big areas that are covered. Let's go on to the next slide, and we'll look at just a couple of them. Okay, as I said, the family and caregiver exception, which goes to the SUD cases and the mental illness and emergency, what it would do is change the standard for how you can release information. It currently says in a provider's, quote, professional judgment, if blah, 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 and then goes on. And so that's a standard. And it basically in applying that standard, it's always been referred to in terms of the physician releasing information. What they're talking about doing is creating a new standard that would be a, quote, good faith belief that the disclosure of information would be in the best interests of the patient. So in this case, if your patient's overdosed or is in the hospital and the family comes forth and says, we're here, we want to help, what can we do? This is the time when the information could be released if you have a good faith belief that it's in the best interest of the patient, even if the patient has not signed that this person can have access to their information. So that would be, if that goes through, that's going to affect all of you. And again, we'll have to come back and see what the final words look like. The second area is care coordination and case management. Huge amount of attention is being paid to this. And what you'll see is not just care coordination between your groups and the social service agencies, although there's a lot of time spent talking about that in the regulations, because what they want to do is to allow a more seamless approach when you're handling patients like CPC for Kids program, where you've got kids that need obviously a lot of additional social service support, that it would allow you to basically treat those social service agencies as treating providers and move that data around without specific consent. So that's the second thing. And keeping the other part of the care coordination case management, that's a big shift, is it also gives a more prominent role to the payers and their ability to access data from you all or from the hospital or whatever. And so I believe that as Ohio Medicaid gets into signing contracts for the new round of contracts for the Medicaid managed care plans, that you will have more and more emphasis put on this area of case management and care coordination, and you will see the payers coming to you and asking for stuff that they might not have before, and this will be supported by this new HIPAA regulation. So just keep this in mind. It's not final, but I want you to kind of give you a heads up about it. Scott, let's go on to the next slide. Okay, as I said, not officially proposed, but we believe that it will be proposed once there's a change of administration, and that best guess would be that it would become final sometime late summer, early fall. And so that gives you an idea of what you're working with. And then what OCR was proposing in the rule is once the rule becomes final, you would still have over half a year to implement those changes. So you're probably looking at, I'm going to say January of 2023 before all this, you'd have to be in compliance and you could be cited for stuff. So that kind of gives you the timeline. Okay, let's go on. Okay, so what would you need to do under these potential changes? The first thing that I'd say, and I'm listing this stuff because this is the type of stuff that appeared in the consent decrees. Every single consent decree had similar things that they were telling the practice or the hospital that they needed to do to be in compliance for patient access. So the first thing is they want to see a patient access policy, a written policy by an organization about how patients go about getting information from your organization. This is something you're not going to want to fully write until those new HIPAA regs are updated, because as I said, there were a lot of specific details about how do you do this, whether you can charge for it, whether you can't. And just to put you in the correct frame of mind about this patient access stuff is CMS puts into two buckets what type of information is available. The first type is the information that's available within your EHR system that you could easily generate with a click of a button. So this would be the CCDs that are the summary of care documents that you print out and put, or in, not print out, but you know what I'm saying, create and push to the patient portal, and you can also print it out and use it as a summary of care. And so that they view as an easy way of producing patient or giving patient access to their information. If there's more data than just that being requested, or is kept in more than just your EHR system, then there's like a broader set of rules as to how that gets handled. So you're going to want to see that before you write your patient access policy. But at the very minimum, when Scott and I work with sites, we have them draft patient access policies right now related around how you go about giving patient access to patient portal, whose responsibility it is, what you do if the patient can't get through. So you see what I'm saying, you're starting this kind of basic policy that says, oh yes, I do give access, and here's what we do so far. And then as the HIPAA gets updated, you're going to want to add more information on that. The second thing is the phone app. This was, as going back to what we talked about at the beginning, was a requirement under promoting interoperability program, is that everyone had to create access through a phone app. And from all the vendors that we know that you all use, I believe all your vendors already offer that. But what you need to do is to have a policy. If the patient comes forth and wants to use a phone app other than the one that you're offering or that your vendor offers, and you don't know what to do about it, you want to have something written on your website saying, if you have questions about phone apps and it's not in the information we've given you, contact this number. And then you take that down, and you have policy as to how to handle that. Remember always, I think this is important to come back to, remember that with phone apps, you are in very soft territory as far as security issues. And so CMS had to write into the rules about 2 years ago, because of the complaints from the hospitals, that there was a right to deny access to phone apps if there was a security issue, because otherwise you don't know who's accessing your EHR's data. So that's number one. But the second thing to keep in mind is CMS is really sensitive to this issue of phone apps being uncertified, and anybody can make them and anybody can produce them, and you're required to give the patient access. But what does that mean from a security viewpoint? So what they want practices and hospitals to do is, they put in quotes, they strongly encourage sites to actually produce patient education information about security issues that can exist around phone apps, because once the data leaves your possession, your EHR system is certified. You yourselves are covered entities and are subject to HIPAA. But once it leaves you and goes to that phone app, there is no HIPAA security protection, and there may not be adequate security. And so they want to see education going to the patient about that. So again, that's something I'm sure people, your vendors and other people, will have stuff that you can use. Case
and
management.
Kathy,
Yeah.
Kathy, just to make a pointer on the technology behind the phone app with the API, we are kind of in an odd spot with that, because initially when the API requirement came out, there really wasn't a defined standard that the vendors had to use. Some of them used FHIR, some of them just used another open API format. So CMS, realizing that, it was also limiting the third-party development. So there's really not a lot of third-party apps out there that support these APIs because there's really no true standard. CMS fixed that with the interoperability through the Cures Act. They now require the FHIR standard for the phone apps, but that doesn't truly become a drop-dead requirement until, what is it, Kathy, 2022?
I think it's the end of 2022. I think it's December 31st, 2022. And for those of you who, like me, are not geeky and don't know what FHIR is, it's just a specific standard put out by the HL7 group that says, you know, here's the technical side of how we're going to connect so that everybody is using the same set of standards around that.
Right. So don't get excited if you don't have a good app to support, or there's just no apps that will access your EHR. As long as you have right now an API available, and when I say API, it's more or less the connection. You have a means for an app to connect, but you just may not have an app to connect to the API. As long as the API is there, it's available for when an app does become available, you're meeting this requirement. And all the EHR vendors have this baked in kind of behind the scenes, though maybe in that weird transition where they're not FHIR standard yet. Sorry, Kath, I just wanted to.
Oh, no. And the other thing I'd say, that Scott and I have had bets riding on ever since this whole interoperability stuff started with APIs, is we believe that the end product of CMS pausing the certification or the information about APIs, because they had wanted everybody to do this like 2 years ago and people were screaming bloody murder. But what we think they're headed towards is a complete certifying program for phone apps, because there's just too many concerns around the security. But that is a to be decided. We will see within the next 6 to 12 months if that is actually the way they go, if CMS does it the same way that they have certification for your EHR system. So, and then the last thing that I'd say, kind of to keep on the back burner, but recognize that you'll need to do it when these HIPAA rules become final. You absolutely need to have staff training around the new HIPAA requirements, especially how you give a patient access to their information. Okay, let's go on to the next slide. Okay, what we're going to do now is kind of shift from the patient access area and talk about the technical side of what's going on with the Cures Act and then how that affects what we do in Ohio, because it's slightly different than what we've talked to you about before, but it's stuff that you should be aware of. So I'm not as concerned about you all getting audited or accused of information blocking, but you at least should be aware of what is expected, and you are completely covered for those of you who are CliniSync members. So let me show you what we're talking about. Okay, let's go on to, many of you have heard us time and time again about if you're not already connected and you need to get connected, obviously you can let Scott and me know. But the bottom line about how we work, and hopefully I would think most HIEs would, is that if you want to connect and be bi-directional, bringing information in and pushing information out, that we work as a team with you, that we do it, we have you contact your vendor, and then we have your staff involved, and that we find is really the most successful way to get these bi-directional connections done. Okay, go on. Okay, since you all aren't required to report to MIPS, which is a CMS program that replaced meaningful use, we're not going to go through the specifics here, but one of the things that CMS did is they basically are recognizing starting this year that if you are bi-directional with an HIE, fully bi-directional, that you get enormous bonus points in your reporting program for promoting interoperability. And you no longer have to report all your numerators and denominators and stuff. But the three things that they look at in deciding if you meet this requirement, if that you have yourself, you have the HIE is secure, bidirectional, and has the ability to push information with every single patient. And so if you're participating in that type of HIE, and then is the HIE itself capable of exchanging information across different types of EHR vendors, different types of systems? And then the third thing is, do you as a practice have certified technology? So are you in the current standard is 2015 edition cert. So those are the three elements that CMS has laid out as part that they view if you're doing, if all three things exist and you can say yes, that you are deemed to be interoperable. So, and then the reality of this, the bottom line of this is if you're bidirectional this way, what it means is that you're pushing that continuity of care document, which is the standard format for all vendors across the country. You're pushing that to the HIE, and the HIE can then parse that up and combine it with other sources of data on that patient. Okay, go on. Okay, the other thing that I want to point out, because I know we've talked to you numerous times too about everything going on with 42 CFR Part 2, because I recognize that many of your sites, you deal with patients, you deal with SUD records where you need to be concerned about how they move and what the correct usage. But the other part of that is we have had kind of a black hole, not just in Ohio, nationally, as to how to unify information that comes from primary care with information that may be necessary to get from a psychiatric hospital. You know, where if you have a patient who is sent after an emergency encounter and is hospitalized for a while and then comes back out, that's really has been a black hole. And I can tell you, Scott and I have stories about this, but the reality is many of the psych hospitals, whether they're the private psych hospitals or the public ones, do not even have electronic health records. Many of them are on paper. And so it's really been a hard lift to get them as part of the interoperability network. Well, what CMS did at the beginning of this year is they set up a new requirement for every hospital in the country. So it's the small hospitals, the rural CAHs, it's the big acute care hospitals, and it includes the psych hospitals. It's the first time I've ever seen them try to pull psych hospitals into what goes on in interoperability. And all three groups are required effective the end of April, this April, to put out notices to treating providers of admissions and discharges from their inpatient and their ED units. And I think just about everyone on the phone is using our notify functionality. So you know what we're talking about, that there's a process in place. They don't specify the chapter and verse, but they basically do say, you know, most of the HIEs are a good source of doing this because, you know, I know we've done it for almost 5 years, and it allows that information to flow back to the primary care provider. But what this new requirement is saying to the psych hospitals, hey, you need to get on board here, because the difference, and I know we've told you this when we've talked about this problem with Part 2 data, is even though you may not be able to get all the information about a patient, you can definitely get information about admit and discharge, you can get information about the ED visit. And so this is codifying that to include psych hospitals. Now, stepping back a minute, and what I said about them, many of them still being on paper, the way that the reg was written, and it changed between the proposed and the final, is CMS was specific. They went back in and included practice management systems. So if every hospital is going to have a practice management system for billing purposes, whether or not they are on paper. And so when CMS wrote that in, it was with an eye to allowing the psych hospital, requiring the psych hospitals to send out these notices as long as they have that HL7 connection that tells the HIE that that information is available on a patient name, who's being admitted and who's being discharged. That can go into the packet of information that goes to you all as primary care providers to let you know the status of your patients. And so I personally think this is going to be huge. It's actually probably as valuable for you as the change in the Part 2 consent. And I know we as an organization are just starting to work with the psych hospitals because they, with OHA, the Hospital Association, to bring them up to speed on what they need to be doing and what connections they need to have and stuff. So I'm going to guess they're not going to be fully compliant come April, but it is a process and they can start in the process and you can benefit from that. So we'll talk about that some more. And while I'm thinking about it too, just the other part to this is when we talk about Part 2, I know that, you know, we had for a year and a half talked about, well, actually since last year when the law changed, we talked about how there were going to be regs out no later than January because the law changes in March and we needed some guidance and yada, yada, yada. Well, I don't know how many of you are true policy hounds when it comes to the federal stuff with everything going on. But the reality is when the break-in at the Capitol happened last week, that night, one of the people who resigned was the woman who runs SAMHSA and the doctor who runs SAMHSA. And she had actually been our contact, as we told you. We've been working with a team at both the state level and then nationally to help draft the regulations around the Part 2 changes to make sure that it could fit well into the workflow that would be necessary to push information electronically for Part 2 data. And so honestly, I don't know where that's going to leave everything because she was the contact person for SAMHSA generally around these proposed new regs. So we'll just have to come back. We'll let OACHC know. They know we are like bird dogging this and they know that you need this information. So as we get updates on this, or hopefully maybe they were even far enough down the road in drafting those regs that they will come out over the next month or two, but we'll keep you posted on that. So those are the two things about the psychiatric area that I wanted to make sure that you were aware of. Okay, go on. Okay, I'm going to spend just 1 minute on this and then we're going to move over and show you something. And what we're talking about here, a national framework, you can go on, Scott, to the next slide, is we talk so much to you about what goes on in Ohio. But one of the things that was really clear from the interoperability regulations is they are not talking just vertical integration or horizontal integration across like practices and hospitals in a given geographic region. They're talking vertical. They want to know what's happening at the national level that's going to impact what you're doing at the local level, and they want everybody to have that as part of their interoperability. So here are the names. Again, you don't need to really delve into this too much, but I want you to be aware if you're part of CliniSync, and it may be with HealthBridge, I know they have connections nationally too, but so that you understand that you also have national coverage. But here are the 4 big HIEs at the national level who move data in different ways. Direct Trust is the one that does the messaging, secure electronic HIPAA messaging. eHealth Exchange is the HIE that for the most part is responsible for moving information between federal agencies and non-federal organizations like the HIEs like us out in the regions. Care Quality and Commonwealth are the ones that you hear about the most because these were built, the Commonwealth especially was built through the vendors. I'm sure a number of you will see one of your vendor names listed there, ECW, Athena Health, Cerner, Meditech. And so that's why in many cases, your vendors were like really nudging you to become a member of these HIEs because they had been backing them. But the reality is the strategy is actually a little bit broader than this because eHealth Exchange kind of becomes the centerpiece to move information amongst these various HIEs. And when you're talking at the national level, you're not so much talking one site to one site, you're talking huge HIEs with huge HIEs exchanging across a standard set of guidance. And this is where we come in. Okay, Scott, go on next slide. This just showing you some of the people who are involved in those particular HIEs. So go on. Okay, without getting in, I'm not technical, as you know, so I'm not going to be real geeky about this, but I just want to point out we are very involved in these national HIEs. The eHealth Exchange is really, as I said, it's the big hub that's moving a lot of the data around amongst the HIEs. And from your perspective, what you get out of this is that you will know if you use our community health record that you have access to VA records and DOD records that come through to us through our connections with the Health Exchange. So okay, go to the next slide, please. The other thing I'd say about eHealth Exchange is as this national network starts coming up and getting going, which it has now for a couple of years been exchanging data, we have been what's called a responder. We, CliniSync, when there's been a request from another HIE through eHealth Exchange for data, say for a patient who's in Florida, it comes to us and we respond. We have now built it bilaterally where we also are an initiator. So if you need information on a patient and you push the button for it, it will go out and query all these other HIEs nationally that are connected to the eHealth Exchange hub. Okay, go on. And this is just, again, same behind the scenes, these groups get connected. Okay, go on. And you can't forget Direct Trust, because that's still a big thing, is to be able to exchange those secure emails. And we actually were one of the, not founding organizations, but Dan, our CEO, has sat on their board for a long time. Okay, go on. Now, the next few slides, we're not going to go through together other than to flip through real quickly because Scott's going to move to something else and I'll show you. So I've got a slide showing, wait, go back, Scott, 2 slides. Okay, we've got the hospitals listed by region. This is what we traditionally have shown people so that you can look to see who's connected. Go on, next slide. And then we had a slide that we'd started like a year and a half ago about all the non-hospitals that we've started connected that are ambulatory sites or behavioral health or some of these other things. And then the next slide are the labs. And what we found is we just have so many people that are engaged in bidirectional exchange now that are building with us that we have moved to a different way of presenting this, which we're totally transparent. All this information is public. Scott, why don't you pull up and show everyone what we just put out is for information for people who use CliniSync, so you can check and see who else may be providing information.
Yes, ma'am. This document gets sent out with our support newsletter. Dave Zupkovich, who's over our support area, pulls this information together, sends it out. I believe he sends our support newsletter out quarterly, but Kath, I'll turn it back to you.
Okay, so what you're seeing, it's basically taking those slides and putting them in. We had to finally, put it in an Excel file because there's just too much information. If you look over, as we go down, we'll show you in a minute that some of the places have numerous facilities. Don't go. The next column is that they contribute CCD. So that's saying that they're fully bidirectional. And then the last column you see is primarily used for the hospitals to show what the hospital feeds are that we get. Now on the ones, we'll flip down here in just a second, but the ones on top are, for the most part, Scott, go up a little bit so we can go to the top of the list. I just want to point something out. Okay, so what you're seeing, you start seeing more and more of the behavioral health centers. We've got the Buckeye Ranch. We've got a number of sites, and these are separate than all the sites that are attached to hospital systems that may have an integrated EHR, because then they show up under the hospitals. But here's what all the what I call the individual sites that are fully integrated. Okay, go on down. Let's look at the hospitals for a second. So what you see here on the right-hand side is it shows, are they doing ADT information, which all the hospitals are, admissions, discharge, and transfer. And whether there's a lab feed, whether there's a path feed, whether there's radiology, just so you understand how much information we're getting from people who are part of the network. Then if you look at Cleveland Clinic there, because in these huge systems, you may have actually many hospitals, same is true like Ohio Health, it will list all the various hospitals that are part of that network that are integrated. And then if you go down further, Scott. So you see it comes up, and like, for example, UH in Cleveland is, although they're fully integrated, they had a different business model, and so their EHR system is not, their ambulatory site is different than their hospital one. So that's why they're all listed separately. But otherwise, you have a combined view. So all the ones that you're seeing as hospitals there, if they have an integrated system with their physician groups, then the physicians will automatically be bidirectional also. So that's about it. I didn't want to run over our time, but I wanted to give you just a little bit different twist on what to be thinking about as far as interoperability, and to recognize how much information is available to you through the HIE, and to get an idea of what's being contributed for that community health record. And over the next time that OACHC needs us to come back, another thing that we may want to talk about is the consolidated CCD and the information that goes into that. But are there any questions before I turn it back over to OACHC? Okay, guys, I guess it's back to you. Avni and Jessica and Ashley and Tiffany, back to you guys.
Thanks, Kathy. I'm going to go ahead and we're just going to share some quick announcements. This was in the agenda that was sent out this morning, but these are just some announcements of upcoming webinars and technical assistance that may be of interest to you all. So I'll let Jessica kind of kick us off.
Thanks, Avni. Yeah, the first one that we wanted to share with you under resources, webinars, and other was Jess and Azara webinar for Heart Month. They are going to be talking about the utilization of drives and the tools available to help identify those patients at risk of developing heart disease or managing those patients. And we included the link there to register. That will be February 18th at 2 for anyone who wants to join that webinar. And then a couple webinars under Gold B, Advancing Interoperability. We do have another webinar that we worked with Blue Novo to provide you all on the 21st Century Cures Act, interoperability, information blocking as well, going into some of your EHRIT system requirements for this, some of the workflows, policies, procedures, different organizational requirements. And really what you'll need to do to kind of meet these requirements. So additional webinar on the topic there. And then the High Tech Advancing Interoperability Learning Collaborative. This is a 5-session learning collaborative that you guys can join for free. There's more information on what each session will be about and when those dates are. I would encourage you all to join this learning collaborative. It's focusing on using technology and data sharing to bring health centers together to coordinate COVID-19 care and response. So some of the topics that they're talking about in each session is the Cures Act again, major interoperability initiatives, improving operations through interoperability with claims data, ADT data to kind of enhance care coordination. Looking at coordinated care through the state immunization registry, and then looking at the future of interoperability. So I think this will be a really good learning collaborative for you all, so feel free to register at that link as well. All right, and I think I'll turn it over to Tiffany now to give some of her updates as well.
Thanks, Jessica. So these have been posted in Slack, and some have been emailed out to you, but since they relate to Goal C and the behavioral health integration and treatment of patients with substance use disorder, I wanted to relink them here for the HCCN. So there is a high-tech webinar that's going to be covering some of the 42 CFR Part 2 revised changes from July of 2020. But also some information on what the CARES Act will bring this year in 2021 and some health IT considerations. So that's going to be January 19th at 2 p.m. and the link is there to register. Also just wanted to mention as part of Goal C that SAMHSA has released an executive order back in December of 2020 regarding the need for mental health, more prevention for mental health, crisis intervention, substance use disorder. It's a long document. It's titled Saving Lives Through Increased Support for Mental and Behavioral Health Needs. And really it calls for a creation of the Coronavirus Mental Health Working Group. But there's some interesting data from the CDC and other sources that have studied Americans over the time of this pandemic and how they've been dealing with mental health, some staggering statistics on substance use disorder as well. So definitely interesting if you have a chance to look at that. And then there's one other thing, and Avni, I don't know if it's on the agenda, but the BIPIC community of practice opportunity that's open to everybody. I can link it in Slack. It came out in the HRSA Digest a couple weeks back, but starting February 2nd, there's a community of practice opportunity for health centers that are interested in learning more about health center integration, including both primary care and behavioral health. Topics will include quality improvement, quality assurance, HIT, population health, and also strategic planning for your organization. So this begins February 2nd and runs all the way to April 22nd. And if you're interested, we'll just send that out afterwards. So you can see that as well.
I apologize, Tiffany, that is not on this agenda, but we can include it, and then I'll send an updated version of this agenda, as well as Kathy and Scott's slides and this recording. We'll send that out to you all so that you'll have access to all of these resources, as well as the last resource that Tiffany mentioned.
Thanks, Avani.
And then the last announcement that we had is Q4 HCCN data submissions are now open, and you can submit data via the SurveyMonkey. This link is also going to be available on the Ohio CHC webpage, the HCCN webpage. I will also link that when I send this out. We are asking that this data be submitted to us by the end of January. I think I have it for January 28th, but obviously if you guys need a couple more days, just let us know. It is important that you submit this data to us because we will be using this data to give HRSA an update of each health center's progress on the HCCN goals. So if you have any questions or anything like that, please let us know. I also have created a PDF version that includes all of the questions that we're asking through the SurveyMonkey. I know it's difficult in SurveyMonkey to go back and forth between pages, and so I'll send you guys a PDF copy of the questions as well, so that you're able to get an idea of what kinds of things we're interested in looking at, and you can prep prior to opening the SurveyMonkey. I think that's some feedback that we received from you all, so we'll try to fix that to make it a little bit easier. But other than that, those are all the announcements that we have for upcoming webinars, technical training and assistance. If you guys have any questions for us, or have any particular questions related to this presentation, I'll also include Kathy and Scott's contact information so that you can talk to them directly as well. And with that, we can go ahead and end for today. So have a great rest of your week, everyone. Thanks for joining.
Thanks all. We'll talk to you later.
Thanks.
Bye-bye.